Going. Welcome everyone. Welcome back to another edition of Tumor Talk. This is the collaborative effort between Lenox Neurosurgery and the Journal of Neuro-oncology, where we get the chance to sit down with the authors of recently published articles in the Journal of Neuro-oncology and discuss really the reasons, the results, and the rationale for those studies, and the relevance to the treatment of brain and spinal cord tumors. As always, I'm joined by my esteemed panel, Dr. Gautam Mehta and Jason Sheehan, both from the Journal of Neuro-oncology. And today we're pleased to invite Dr. Veronica Chiang from Yale, who's discussing their recent paper, Laser Interstitial Thermal Therapy versus Bevacizumab for Radiation Necrosis in Previously Irradiated Brain Metastases. So Dr. Chiang, if you want to introduce more about yourself or just jump right in, the floor is yours. Welcome.
Okay, so thank you, Dr. D'Amico. So we're the Brain Metastasis Neuro-oncology group at Yale. And so on behalf of all of our authors, and so co-author with me is Joachim Bering, who's hopefully joining us later. On behalf of all of us, I'd like to thank you all for the invitation to participate in this webinar, and especially for your interest in our paper. And so the rationale behind the paper over the past 2 decades or so is the treatment of brain metastases has moved away from whole brain radiation therapy because of its neurocognitive toxicities. The use of radiosurgery as a focused radiation tool has become first line. And patients are living longer now because systemic therapies are getting better, and so they're often undergoing second and third and fourth and sometimes 8th time radiosurgery. And so the national use of radiosurgery, as you see here on these 2 charts, has grown exponentially from the early 2000s into the recent decade. So unfortunately, the most common complication after radiosurgery is lesional regrowth. And so, what you can see here from these images is all the way to the left, a lesion that was treated with radiosurgery. You can see that 4 months later that it had a really nice response. And then at 18 months, not only has the lesion started to regrow, but it's bigger than it was at the time of the radiosurgery. And there's a significant amount of edema around the lesion that now makes it symptomatic. And so back in the day when we didn't really understand what this was, we surgically resected these lesions. And what you can see on the right is that obviously there can be a variable amount of tumor that's causing these lesions to regrow. But in our surgical series, there was actually about 50% of these cases where there was no tumor found whatsoever. And this condition is now known as radiation necrosis. So radiation necrosis is now defined as a self-perpetuating focal non-malignant inflammatory process related to the death of healthy tissue caused by high-dose radiation therapy. And for those of us who treat this condition, these lesions can appear and behave and be just as morbid as a regrowing tumor. The risk factors associated with developing radiation necrosis are high prescription dose per fraction, larger volume, longer survival, use of immunotherapy, and use of repeat radiosurgery. But even knowing these risk factors, it's not always possible to predict. And so these are the currently available management options. And so there's a fair number of them. The first one is obviously to try and avoid causing it. But given that, that it's still difficult to predict who will get radiation necrosis, it's been difficult to prevent. So from the medical side, steroids have always been first-line management, but chronic use of steroids have many side effects, as we all know. There have been many anecdotal reports about aspirin, anticoagulants, vitamin E, pentoxifylline, and hyperbaric oxygen, but that really the only agent that's been shown to work in a randomized fashion is bevacizumab, and we'll talk about this in a little bit. From the surgical side, we've been able to prove over the last decade or so that that craniotomy, is very effective, but obviously not everybody wants a craniotomy. This new tool called laser thermocoagulation has come into being, and we'll talk about that also. And so the reason for continuing to pursue surgical management, even though it's not a very popular option, is that we were able to demonstrate back in the day that that by surgically removing these radiation necrosis lesions, so listed as type 4 here, that there's actually a huge survival and local control benefit. And so in our institution, we continue to surgically manage these patients, both for decompression as well as trying to get diagnosis, so we can help these people with what to do next with their intracranial problems. So just as a quick review, LITT is the new surgical option. It stands for laser interstitial thermal therapy. In essence, LITT is thermal ablation of a lesion using laser generated heat. And the principle behind the procedure is that a laser fiber is placed into the middle of the lesion. And as laser light is emitted and diffuses through the tissues, it can either be reflected, scattered, or absorbed, as you can see on the bottom. And the absorbed light that then gets turned into heat and then can be used to ablate the lesion. Different tissue compositions absorb light differently. And what we've learned by experience is that radiation necrosis tissue, for whatever reason, absorbs light very well, especially when compared to the surrounding edematous brain. And LITT results in preferential ablation of the radiation necrosis lesion. And so what you can see in this next video is basically the laser placed into the middle of the lesion. The laser is turned on, and then under continuous MR imaging, we can watch the growth of the yellow line, which is the calculated ablation line, relative to the blue line, which is the outline of the lesion. The laser can be turned off when the ablation line approximates the edge of the lesion, and that allows us to tell us when to turn off the laser. Patients like LITT, they end up with a very small incision, as you can see on the left. The mechanism of action of LITT is unclear. What we think happens is that we heat to the edge of the necrosis lesion, and it's really the inflammatory rim that's being ablated and not the central necrosis. As you can see, though, we've had some good results with LITT, where patients have been able to come off steroids relatively quickly and get good long-term control, as you can see with the images on the right. And so the data on LITT is still relatively young. The largest study that's been put out to date was known as the LASER study, put out by Manmeet Ahluwalia and his group in Cleveland, which showed that LITT can be safe and an effective way of treating radiation necrosis with good survival, good local control, and allowed for preservation of functional status and neurocognitive function at 6 months. But as you can see, the numbers are small in this study. In comparison, for Bevacizumab, the randomized study that was done by Levin and his group was published back in 2011, so it's been a while. And in their 14 patients with radiographic or biopsy-proven symptomatic radiation necrosis, they randomized to Bevacizumab versus placebo saline. And looking at lesion size by gadolinium enhancement, as well as T2 flare, as well as symptoms, they were able to demonstrate 100% response for Bevacizumab and a 0% response to placebo saline, with only 2 failures over 10 months. And so this included both the group that started with Bevacizumab as well as those that had to cross over from the placebo into the treatment group. So the argument for Bevacizumab use is actually pretty strong, and the argument for LITT is still growing at this point. So our group then kind of decided to go back, because within our institution, I think it's not completely clear who gets Bevacizumab and who gets LITT. And so we wanted to try and get an idea of how the two tools compare to each other. And so we did a retrospective study. We looked at all patients between 2011 and 2018 who got one treatment or the other for brain metastases that were regrowing after radiosurgery. And they had to be more than 3 months out after radiosurgery, so we weren't getting the acute inflammatory changes from radiation. And so you can see in the LITT group that 100 patients during that time got LITT and a whole bunch got excluded for other tumors and in the other indications, and that left 25 patients overall that, that fulfill criteria. In the bevacizumab group, we went and did an extensive pharmacy review, actually, and pulled out 250 patients who got Avastin over the course of that time period, and then excluded, you know, all the patients with gliomas, et cetera. That left us with 13 patients. And so the big difference between the two groups is that obviously the LITT patients all got a biopsy at the time of surgery, and therefore have a tissue diagnosis of radiation necrosis. In the bevacizumab group, the 13 patients, none of them had a biopsy. And so their diagnosis of radiation necrosis was determined by multidisciplinary tumor board review of specialized imaging.
Dr. Chiang,
The outcome, yeah.
for in the LIT group, in the 68 patients who were excluded for tumor, were those mostly lesions that looked like tumor on imaging, or was there some heterogeneity in terms of the imaging characteristics?
So I can't tell you for sure. I think we just excluded them because there was tumor on pathology. But I can tell you from my own experience that it sometimes is hard to tell. And in fact, in my experience, it's easy to tell, I think, when there's tumor. But when it looks like radiation necrosis, so this kind of heterogeneous pattern, kind of pseudopodic pattern, then it's a little bit harder to differentiate for sure. Okay, so the outcomes that we looked at were overall survival, progression-free survival, and then we looked at 3D volumetrics, which we've been estimating in our institution using kind of this estimate using length, width, and height as calculation. We looked at modified Rano criteria, and it was a modified Rano criteria because we obviously didn't look at additional lesions as criteria for progression of disease. And then we used the NCI CTCAE for adverse events. So obviously the two groups, because they're retrospective, you know, are expected to be a little bit different, but the two groups were really quite different. You can see that there was a male predominance in the bevacizumab group. Median age was interestingly about the same, but the median Karnofsky performance status score was a little bit lower in the bevacizumab group. The burden of systemic disease was not significantly different between the two. The percentage who had multiple brain metastases was not significantly different between the two. But what was very different was the median amount of time from radiosurgery to the intervention, whether it be LITT or first dose of bevacizumab. Primary pathology was also not significantly different between the two groups. What was also different was treatment indications. And so what you can see here is that the majority of the bevacizumab group were actually symptomatic, and whereas only half of the LITT group was symptomatic at the time of intervention. And that may be a reflection of patient choice or, I guess, aggressiveness of intervention. The other thing that's a little different in our study, which was a little bit surprising for us, was our median bevacizumab dose, which was 15 milligrams per kilo, which is a little bit higher than the Levin study, which was actually many of their patients got 5 milligrams per kilo and some 10. So that was interesting also. So what we found was that survival was actually significantly higher in the LITT group, and so you can see a median survival of 15.2 months for the bevacizumab group and 25 months for the LITT group. In addition, looking at local control, what we see is actually two very different patterns of response, and so this made the data quite difficult to compare. If we start with the graph on the right, this is our standard 3D volumetric change over time. So on the x-axis is time from radiosurgery, and on the y-axis percentage of volume change. And so if we start with bevacizumab, which is the black line, you can see that there's a rapid decrease in volume following bevacizumab use. which actually lasted quite a while, out to kind of 6 months. But by 12-month follow-up, you can see that it looked like the majority of lesions had started to regrow again. And this was, and so when you then move over to the RANO criteria for bevacizumab, you can see, interestingly enough, that there's about a 15% of patient, small subset, that seems to get a very quick, complete response to bevacizumab. But for the majority of the remainder of the patients, at best, they got stabilization of the disease, and then over time, progressively more and more progression of disease. So this is in comparison to the LITT patient who, as you can see, there's a rapid rise in volume after laser thermocoagulation, which is what is expected following surgery. So obviously, to completely ablate the lesion, you have to heat beyond the margins of the lesion. And in fact, if you look then as this translates to the RANO, you can see that many of these actually fell into the progression of disease criteria. So it's kind of interesting, using the modified RANO criteria can be a little bit difficult to compare one with the other. Over time,
and that's based just on, sorry, that's just based on contrast enhancement, right? That's this.
It is.
That's what you're looking at there.
Yes.
So presumably, this is just an enhancing response to the laser ablation, right?
That's
and
correct.
So it doesn't absolutely represent tumor necessarily, or necrosis. It just represents inflammation of some sort.
Correct. No, that's absolutely correct. And I think that, you know, when, I think, you know, as these people get included into clinical trials or otherwise, it's just going to be important to recognize that there's this expected blip relatively early on, and for that not to be necessarily, recorded as progression of disease.
Did you look at things like perfusion or SPECT there in those edges?
So we actually have
anecdotally.
Yeah, no, we actually haven't really. And that's something that maybe we should do. I think at around 3 months is probably the right time to start looking at that. Because I think up until then, the rims always look really good. And at 3 months is when we start to see some irregularities that make it difficult to know if we've got disease progression. So yeah, that's an interesting point, but we haven't done that yet. It's hard enough to get it for our standard patients. So anyways.
You know, I think you picked the right primary endpoint, though, when you were looking at overall survival initially, and then looking at, you know, arguably quality of life for these patients, because, I mean, we can't underestimate the fact that these are patients oftentimes with multiple sites of disease and confounding factors. So I'm a little less concerned about what the post-contrast enhancing response is, and I think you've shown that is perhaps a little bit less priority in terms of, or at least a little less significant in this patient population treated with LITT. So.
Yeah. No.
Absolutely.
I think that was the point, was that, you know, it's important for us to interpret the data based on, you know, what we expect to see, right, as well. So yeah. All right. And so then, so the last outcomes that we looked at were steroids usage and neurological outcome. And you can see that basically this doesn't look too dissimilar between the two groups, except obviously at last follow-up for bevacizumab, the KPS falls off significantly because those lesions are not well controlled. I think, you know, it's interesting because I think a lot of the studies that are coming up are looking at steroid usage as an outcome. And one of the things that we went back and specifically looked at were reasons for not being able to stop steroids. And it was interesting. I think there were more patients that had non-neurological indications for not stopping steroids than those that had neurological indications. And so we had things like fatigue and lethargy, diffuse weakness, COPD, adrenal insufficiency, and immunotherapy complications in other parts of the body as reasons for using steroids. So I think that's another thing that we should note here. And then lastly, adverse events. And so this, we were actually kind of surprised. I think obviously from a surgical standpoint, I think surgery is still a higher risk factor for most of these patients, but the number of adverse events were pretty low in both groups, and particularly so in the bevacizumab group. And so, many patients, I think, I've certainly heard over the years that many medical oncologists don't necessarily like to use bevacizumab because they worry about the side effects. But in our study population, they were pretty low and uneventful. And so, from this study, we concluded that both bevacizumab and LITT can be effective for the treatment of radiation necrosis with few adverse events, but neither seems to work 100%. There was longer overall survival in the LITT group, but there's many reasons why there might be a selection bias here for that. Local control patterns, as we talked about, were very different between the two groups. And so I think looking at that, though, what might be different roles then for the two treatments. Bevacizumab, when effective, does result in rapid reduction in the enhancing lesion volume as well as the T2 flare, and is less effective long-term. So perhaps it should be used or considered as an option initially for patients with symptoms related to mass effect. And then because LITT causes initial volume increase, but then gets better long-term control, maybe it could be considered to be used later or as a more prophylactic treatment before symptoms arise. And so that was it for the study.
So when I saw the study submitted initially, I was really impressed with it. One, in that it's a critically important issue with radiosurgery, as you well know, about the management of patients with adverse effects and specifically radionecrosis. And I thought, although numbers were small, you're certainly coming from a well-respected group with consistent treatment paradigms. This was an impactful study. So my hat's off to you in terms of the efforts. And I wanted to ask you a little bit more about the question about radionecrosis. How much do you think that this is really binary? I think you touched upon this a little bit, but it might be important for our audience to understand. My experience is that, for instance, that you get a report that says that there's hypermetabolic activity or increased perfusion consistent with active tumor, and then in other instances you get a report from a radiologist, or you get an interpretation that says that this is radionecrosis, even on T1 post-contrast images without perfusion or SPECT or even PET. But how much do you think that there is a real 90% plus one way or the other versus a mixture of radionecrosis and some active tumor? And to your point, do you think that with that mixture, do you think that LITT would be a better treatment for those patients that have mixed response?
Yeah, so I agree with you, Jason. It's it's rarely a binary event. I do think, however, that it's a little bit related to the aggressiveness of the radiosurgery that was administered. So I think that there are some centers that are more aggressive with their radiosurgical dosing, and I think that there are some that are less. But because of that variability, I think there's a huge amount of variability then in how many people get pure radiation necrosis and how many have, probably a majority of people that have mixed radiation necrosis and tumor regrowth. And so we certainly had a combination in many of our patients. What was really interesting, and it's the reason why we've kind of divided it into two groups, is because we had a fair percentage of patients where the pathologist went back and quantified the amount of tumor in the lesion as less than 2%. In other words, small islands of tissue of tumor within large areas of necrosis, and that was that type 3 patient that you saw back in the graph in the talk. And interestingly enough, all of those people eventually failed as tumor recurrence, interestingly enough, with the laser. So it may be that, and so what we were able to show in the laser study actually was that if you're going to use the laser as a treatment, that you must completely ablate the lesion. So subtotal ablation of the lesion does not result in good control in any way, shape, or form if you've got any tumor. Interestingly enough, though, subtotal ablation of radiation necrosis seems to at least result in stabilization of disease. And so I think that's where it's just important to be able to say, just as we choose whether surgery or otherwise is better as first-line treatment for brain metastases, that we just need to take the tool's advantages and disadvantages into account. So
very, very well put. Thanks.
yeah,
But
thank you.
looks like we have a question from the audience. Do you want to field that, or do you want to ask that, Randy?
Yeah, John asked, wondering if LITT or Bevacizumab create any transcriptional changes in gene expression.
Huh. All right. Well, that's not something I know
That's
much
a tough
about. I don't know. Maybe, maybe I could invite my co-author, Dr. Bering, to answer that question.
It certainly is a provocative question. I'm interested to, if anyone has an answer. I don't know of one based upon the literature, at least.
Yeah.
I think it's a very tough thing to study. I mean, you're doing this, you're taking a core biopsy basically before you ablate the entire lesion. I don't think anyone's gone back in after you failed laser for radiation necrosis and taken the tumor out, and done this again. So I would anticipate that there would be changes in partially treated tumor cells, right, or areas nearby. But what those are, I think, is beyond study right now in the short term. Anyone disagree, Dr. Bering?
I don't think I can contribute anything else there. It would be speculative. I agree it would be a very difficult thing to study. Probably someone has looked into it, but sorry.
I agree with Dr. Chiang, though. I think when I first read the paper as well, I was impressed by it. I think it's a very honest paper. I congratulate you guys on that. I think that you ultimately did compare two different groups in a way, which you do expect when you're doing a retrospective analysis. But they were different cohorts for the most part. But what you did do was support, and I feel hone the indications for LITT. And that's important. This is clearly a useful tool in a select group of patients where this is going to give some utility. And, short of a randomized controlled trial where you have, controlled patients, perfectly, and which I doubt we'll see, this is good evidence to support the use in these situations with excellent outcomes. How are you guys using this now? Are you using this to, in a specific population? Does this manuscript or these results change who you look at LITT for?
So I think our paradigm's still evolving. I think one of the reasons for doing the study was exactly to look at this. Obviously, I think we've certainly had failures on the LITT side, and there have been failures on the Avastin side as well. Like I said at the very end, I think lesions that are deep, that have a lot of edema with mass effect, it may be that getting those under control initially might be best with Avastin. The one thing that we have been doing with LITT, and so there's some discussion about whether or not this is perhaps overkill on our part on the LITT side, is that in patients who are getting immunotherapy, the minute their lesions start to regrow, we're not waiting for symptoms to show before we LITT them. And so they never end up on steroids. They never actually go down that path where we're watching to see if these lesions get better before we do an intervention. And so I think the data supports that, in that, many of the asymptomatic patients did very well with their lesions controlled long-term. And that may be the population that gets the best advantage with, longer survival.
One last question, if I may, and that is, because I know we're running close to time, but I wonder if you could comment on the cost associated with these two treatments. I know that management of patients with brain metastasis is an expensive proposition as you treat patients with cancer. But do you have a sense the relative costs of one approach versus the other, at least within your institution? And it doesn't have to be specific numbers, but is one much more costly than the other in your mind?
So I think that, and maybe Dr. Marion can help me out with this, but so from the surgical side, it's expensive. It's a longer day than a craniotomy in the operating room for us. And so that obviously right there racks up the expense. Most of our patients do go to the intensive care unit for a night afterwards, although in many institutions they're changing that. We just don't have the facility to take care of them on a floor for now. And so from that standpoint, I think we've always justified the use of LITT by saying that Avastin's just as expensive, but I don't know that we've actually done the calculations to
I do know that Avastin's expensive, and I know that LITT's expensive, and obviously you'd have to do. It goes beyond the scope of your study, nor by suggesting that it needs to be done, but and be looking at the sort of quality adjusted life years of for these patients, because there was at least in your study a survival advantage to LITT, and so that may be offset by the added cost may be offset perhaps by that additional survival advantage if it's maintained. But
yeah, we didn't look at cost systematically as part of this study, obviously, and the cost has somewhat changed simply based on the fact that Bevacizumab is no longer on patent, and we now have Bevacizumab MVASI, which would result in cost reduction. One thing also that we've done with Bevacizumab therapy is that once we feel that we achieved maximum response, we have tried to taper and increase the treatment intervals. And that is simply based on the fact that patients didn't seem to need to maintain on the induction dose. And at the same time, we were able to reduce cost in a way too, and toxicity. So it would be difficult. I think to be really specific about answering that question, you have to do it systematically. But I think.
Well, maybe we'll see an RCT at some point in the future, but thank you.
Improve patients' quality of life and overall survival. So that
well, until then, your study helps to guide the way. Thanks.
Thank you very much.
Everyone. So we like to limit these to about 30 minutes, which we're right about on. It keeps people interested. This will be posted on YouTube probably by the end of the week. It takes me a couple days. Thank you so much. Congratulations. I think like any good research, we're left with a lot of interesting questions and kind of stoke the fires of how to pursue this research. So congratulations again. Thank you very much, everyone. And we'll see you next Tuesday.
Thank you.
Thank you.